So my name is Johanna Hutchinson. I'm the Director of Analytics and Data Science in the UK Health Security Agency. And it's my pleasure to welcome our speakers, our guests, and yourselves to join us today for the third of our international series of speakers in this joint forum. So the UK HSA came into being on the 1st of October this year. It's a combination of Public Health England, the NHS Test and Trace teams and the Joint Biosecurity Centre that worked together during the pandemic to provide some of the responses into government to help us with the COVID crisis. So going forwards, we're going to focus on 5 areas, and we're building the capability within our structures to be able to support these as we go through. And what's really critical when we're building these structures and thinking about how we'll work going forwards, building on our own excellence, is hearing from others and the experiences of others within and with outside of our communities. So we're going to be focusing on prevention, so taking action before hazards materialise, detection, so surveillance, how we join up data, horizon scanning, and early warning systems, analysis, modelling, evaluation of interventions from what is now a growing and rich knowledge base on COVID and infectious diseases, responding by taking action through delivery and giving tools and advice, and how we engage our citizens with our policies and how we work, and then leading, how we work in partnership with the UK government, with its agencies, with academia, as we're doing here, with industry, but also with our colleagues from further afield in other countries as well. So without further ado, I'll hand over to Sylvia, our partner in the Turing RSS lab, who will introduce our speakers, and I look forward to hearing both the talks and the questions that we come up with in the session afterwards. Thank you.
Thank you very much, Johanna. It's with great pleasure that I introduce the speakers of today's distinguished lecture. In this global crisis for the world, learning how different countries are tackling the crisis, and particularly in terms of how the interface of statistical modeling and public health has functioned, is of profound interest, both to try to draw lessons from the past, but more importantly, to prepare for the future. And so in this series of lecture, we've heard before from Mark Lipsich and from Albert Coe, both from the US, but there's much also to learn from our European partners. So today we're extremely fortunate that we have with us 3 key actors in the COVID crisis in France. Daniel Lévy-Brühl of Santé Publique France, who's been in charge of the unit respiratory infection and vaccination. Unit who was on the front line during the whole pandemic because this unit coordinates at national level disease surveillance activities, monitors vaccine coverage, and discusses health threat with the ministry and provides advice on control measures. After Daniel, our speaker, we will then hear from Cauchemez, who joined Institut Pasteur in 2013 from Imperial College to head the mathematical modeling and of infectious disease unit. The main objective of his unit is to develop statistical mathematical model to increase the understanding of how pathogen spreads and to support policy making. Simon is a member of the Conseil Scientifique COVID-19 of France, which was set up on the 20th of March 2020 and has currently 17 members covering a wide range of specialities. And the Conseil Scientifique publishes regularly comprehensive reports and recommendations. I think it's about 40 reports since its inception. And our final speaker will be Vittoria Colizza, who is Director of Research at Inserm, which is the French National Institute for Health and Medical Research, and leads the EPICS lab, Epidemic in Complex Environment. This lab has a long-standing focus on modeling, in particular infectious disease, and had done pioneering work on flu modeling through Sentinel networks. And the focus is on providing actionable insight for the management of the epidemic. And since January 20, she's been very active in the response against COVID pandemic, advising both French government and international health agencies. So I will now, without further ado, turn to Daniel. I will remind you to post your questions in the Q&A, please, during the talk, because we'll have 10 minutes time for question at the end. I now turn to Daniel.
Thank you very much, Sylvia. It's really my pleasure to be part of this nice event. So just a few words of introduction as regards to the relationship between the modelers and we at Santé Publique France, which is a PH France, I should say. At Public Health France, we decided a few years ago not to invest in setting our own team of modelers, but to rather establish strong links with external teams. For the sake of time, I will not detail the many pieces of work that we have conducted together in the last year with especially the team of the two next presenters. Importantly, we have been sharing for several years a postdoc modeler who is working half-time in Simon's team and with us. It was therefore very easy or natural to benefit from this very strong interaction when the SARS-CoV-2 virus first emerged in early 2020. So we very rapidly set up weekly 1 hour long virtual meeting with first those two teams, and secondly expanded to one more team. And during this meeting, Santé Publique France could express its need in terms of support from the modeling field, where the modelers could expose their ongoing work and especially their need for access to the data. And of course, in that respect, the on-site presence of this postdoc modeler I just mentioned has been facilitating in giving access to our database in full respect of GDPR regulation. And just to give you some practical examples, those collaborations help us to set a monitoring tool of viral dynamic of the virus through setting bi-weekly monitoring of are effective, applied to different databases that we had created. It made possible short-term prediction or rather scenario at the request of local health authorities who have regional offices and mainly from overseas. And also it made it possible to share at very early stage the work that they were conducted, to which either we contributed or at least we were associated at a late stage before this was put in a public domain. And this was very instrumental in the very numerous memos and position papers that Santé Publique France had to prepare for the Ministry of Health to advise him on control measure. And we also prepared several documents which summarize the conclusion of the recent modeling work for the Ministry of Health. So in brief, as I guess Simon and Vittoria will also mention, even if Santé Publique France has not been the only link between the modelers and the policy decision makers, I think it's fair to say that it was and remain an important and fruitful channel of translation of science to politics that pre-existed to the crisis, but was transcendent throughout these last 2 years. And I hope it will continue even further after the crisis is over. Thank you very much for your listening, and I will now hand over to Simon.
Thank you, Daniel, and thanks again for the invitation. So Sylvia asked us to explain how modeling was used in France to support policymaking, and so I will start with that, and then Vittoria and I will give a couple of illustrations of the work that we did during the pandemic to support this policymaking. So the first point to make maybe is to look a bit at the situation we had in France before COVID-19. That was actually quite different than the one you had in the UK. As Sylvia said, I used to work in the UK, and in 2009, I could see how modeling was integrated into policy making. At the time, you already had SAGE, you already had SPIAM. So you have this very long history of policymakers working very closely with modelers to support decision making. And I should say that's not we don't share the same history in France. In 2009, for example, during the flu pandemic, there was the use of epidemic modeling was very limited, and there was no SAGE, there was no SPI-N. That being said, there has been a real increase in interest in recent years. And as Daniel mentioned, these last few years prior to the pandemic, we had tried very hard to strengthen collaborations with modeling teams such as Vittoria's and mine and Santé Publique France, contributing to providing modeling support to a number of epidemics, for example, Zika and dengue epidemics that occurred in French overseas territories. And as Daniel said, Santé Publique France was really the interface between modelers and policymakers, and we would always work with Santé Publique France that would then report to the Ministry of Health. The other maybe difference with the UK is that our community is smaller than, modeling community is smaller than the one you have in the UK. And prior to COVID-19, there wasn't so many interactions between the different teams. And so then COVID-19 arrived, and the way like scientific advice is given to the government is through agencies, so Santé Publique France, but also the Haute Autorité de Santé to design vaccination strategies, or the High Council for Public Health. And at the beginning of this pandemic, the Minister of Health and the President decided to create this scientific committee that Sylvia mentioned in her introduction, that initially was made of 14 independent experts, doctors or scientists in fields that could be of use for that pandemic. And so I was the one representing modeling. You will note that the creation of that committee came relatively late if you look at the timing of events at the start of this pandemic. So the first meeting of that committee, that was on March 12th, was a meeting where with the president, where we directly had to jump on very difficult questions about whether or not we should implement a national lockdown. And 5 days after that very first meeting, a national lockdown was implemented following our advice. Of course, this group of people worked with the French agencies, and we had representatives of Santé Publique France and the High Council for Public Health, but also a lot of other scientists, and Vittoria, for example, presented their work a number of times in our meetings. And after the first wave, at least, many more interactions with equivalent committees abroad. And so overall, we met a lot and generated a lot of reports and notes. And looking back at the evolution of the relationship between scientists and policymakers and politicians, it clearly evolved throughout the pandemic. And I'm sure you had similar evolutions, where in the first wave, most of our advice was actually followed up by policymakers. We were more cautious about the reopening of schools, but they did it anyway, and it worked actually quite well. Then in the second wave, starting in August, September 2020, was a bit of a confusing time for that relationship between science and policymaking, because so there was a lot of confusion in the media, because you would see like all day long on TV, scientists saying very different things on what would happen. Often people actually with very little expertise in infectious disease, and that really generated a lot of confusion in the public, in the media, and among policymakers. And eventually, the kind of wave that we had alerted that the scientific committee had alerted about arrived, and so that highlighted the relevance of such a committee. Then the third wave was maybe the time when the relationship between scientists and policy and politicians was the more tense, and that's because it was a time of high uncertainty with both the rise of the alpha variant and the slow rollout of vaccination, where our committee felt that the slow rollout of vaccines would not avoid important stress on healthcare due to the rise of the alpha variant, but so we advise for stricter measures, but then clearly policymakers also have to consider, economical and social aspects. So they decided to wait and eventually had to implement these measures, but only later on. And then the fourth wave was actually became simpler, like the relationship became much simpler, where we quickly alerted on risk associated with the Delta variant at a time when vaccination rates were going down, even though our coverage wasn't that big. And so we really helped shape the sanitary pass that was implemented in France, that I think was a huge success, in that it really pushed vaccination coverage up in all age groups, including teenagers, where we are now close to 80% vaccine coverage. So compared to the pre-pandemic period, when we only had to interact with Santé Publique France that were used to work with us, that period opened up many more interactions with different organizations, with the scientific committee, of course, with the Ministry of Health, where we are providing like short-term forecasts I'm going to talk about in a minute, to support healthcare planning. Of course, Santé Publique France on many aspects, including surveillance, and then the Autorité de Santé on vaccination strategy. And that really generated at some points some difficulties, in that Vittoria and I were not, at some moments were not had difficulties ensuring that the modeling results and uncertainties around these results were correctly reported to policymakers, just because we had many layers from us providing a result to that result being reported and summarized and potentially modified by layers of people that were not necessarily experts in our field. And that's really the kind of problem that are expected when you start that kind of relationship. So these problems were progressively, I think, resolved. And so my team has, since from the start, generated now more than 100 reports, and then Vittoria and other teams have also contributed to often different and complementary aspects. And one clear positive outcome of that pandemic is that it will have, I think, considerably strengthened our modeling community. That, again, as Daniel said, initially we just had a few teams with the experience to generate that kind of analysis, working with Santé Publique France very closely, and that number progressively increased. And so from the end of last year, we started calls for a larger group of modelers working on COVID. So initially they were like informal exchanges, and now we are moving into something that is much better structured and formed, and in a new action by the funding agency for infectious diseases in France that will really help like maintain and strengthen this community and interactions within the community. Okay, so that was for setting the stage on the kind of how we worked in France. And now I will just give you two illustrations of work we did during the pandemic. Going back first to our very early assessments of the burden of SARS-CoV-2 in France, where we used a deterministic model very similar to the many models I'm sure you've seen on COVID-19, accounting for the age-specific mixing patterns and the gradient of severity by age groups that we generated very early on, and from the very beginning we used that model to support healthcare planning, like short-term healthcare planning. And the big question we had, of course, at the beginning was that we could see the most severe infections, but we had difficulties assessing the overall proportion of French people infected by SARS-CoV-2. And so to be able to make an assessment about the size of the pool of infected individuals in France, we developed a framework to jointly analyze the passive hospital surveillance data we have for France, along with data describing very detailed outbreak investigation in a cruise ship where all the passengers were tested, and so we knew who had been infected and who died, and so from that we could make an assessment of the proportion of mild infections you expect from one severe case. And so by jointly analyzing these two data sets, we were able to provide early estimates of the risk of being hospitalized, of dying if you're infected by SARS-CoV-2 for different ages and gender, and then using that information, generate the first map of immunity for SARS-CoV-2 at the end of the lockdown. And at the time we were still in the lockdown, so we were assessing about 5% of the population infected, with higher proportions in Paris area and Grand Est. And for few months we didn't have seroprevalence results to validate these estimates, and that's why these numbers were so important to assess the risk of a second wave. And when the seroprevalence results arrived, they were very close to our results, so that was a very important validation for us. And so for a while we kept on using that model to do short-term forecasting of to support healthcare planning, but we were calibrating this big model to hospitalization data, and we are not very happy with that approach, because hospitalization is a very relatively late signal, so it takes time to pick up changes in the dynamics. And also we were wondering whether we really need that big model if all we care about is forecasting the next 2 weeks. And so we made a systematic evaluation of all the models we could think about to make this forecast using different type of statistical techniques, and also different kind of metrics to assess the dynamic, and then also many different predictors that could potentially improve our forecast, modality predictors, epidemiological variables beyond just the number of hospitalizations, and also meteorological variables. And so, of course, initially we started that evaluation on a relatively short time period. Now we have more data, so we do an evaluation of these different models in a two-stage way. First, we evaluate the models individually, and then we test what we call an ensemble model, where we take the best 6 models and we make an average, and we see how this ensemble performs relative to individual models. So this is just showing like the forecast of these different individual models. And when we then, looking at different metrics, assess the performance of this forecast, So either metrics looking at the point forecast or the range of values of the forecast. We find that actually the models that rely not just on hospitalizations, but on other predictors, mobility or earlier epidemiological indicators, meteorology, work much better than those that rely on hospitalizations only, that you can see in blue here. So I don't have time to go in the details of the predictors, but usually the best performing models have at least one predictor that is a mobility variable and another one that is an epidemiological variable. So this is just showing, like, if we look back at these forecasts made at the 3 days ahead, 7 days or 14 days ahead, you can see how these forecasts worked for different French regions. And on average, we find that the ensemble model, so the average of individual models, works better than the individual models. So I will stop here with a few words of conclusion. So clearly that crisis has really changed the way modeling is used by policymakers, with a very clear explosion of demand by a much wider range of actors now, leading again sometimes to a number of challenges, and that it always takes time to learn to work together. And we had this shift with the creation of the equivalent of SAGE in France, which really was a new thing in the French environment. So it will be interesting to see if in future crises we keep up with that model, or not. And then also the positive point was on the strengthening of our community with again larger number of groups, more coordinated, and we really hope we can maintain and keep on this level of integration in for future crises. I'll stop here, thanking a number of collaborators, and give now leaving to Vittoria to do her presentation.
Great, thank you very much, Simon. I would like to thank the organizer for this opportunity. This is really a privilege for us to be bringing our experience into how modeling have helped informing some of the decision making in the COVID-19 crisis in France. And first of all, let me thank, of course, behind me and behind Simon, there is a large set of collaborators. Much of this work has been done in collaboration with Santé Publique France, but also with other actors coming from research and also from the industry. If we go back again a second to the history of the pandemic, clearly as a modeler, and for sure this has happened exactly in the same way in the UK. We have been solicited so many times throughout this crisis, and sometimes, of course, the questions were of clear societal health impact. In other cases, questions were more for anticipating what we could expect in the upcoming weeks and future. And in other situations, maybe some of these questions were more, for example, relevant in terms of understanding what had happened and then trying to learn from the past experience of the few months when for example, protocols were changing in order to do better in the future. And so clearly, once again, when the crisis started, as modelers, we had a set of different approaches and models that were ready to respond in principle to a crisis. But at the same time, the big difficulty, and clearly COVID-19 pandemic has pushed a lot on this aspect, was the availability of data. So all of these models, then we can increase, of course, the resolution, we can increase the information we integrate, etc. We can, in that sense, also provide more higher resolution responses to some of the questions, for example, whether we need to close schools or not. But at the same time, these models need to be well informed by data, and especially for a pandemic like COVID-19 that forced us to change behavior because of restrictions, but also because of adaptive behavior. This has been enormously challenging, and probably this is an aspect in which, looking at lessons learned, we could have done better. So in some senses, we had to rely on a few things that were available, a few things that we were able to collect over time, or on proxies or on available collaborations. And so, for example, with a range of possible data that could be integrated into these models, from networks of contacts to the use of mobile phone data in almost real time, to crowdsourced surveillance, so providing us information not only on COVID, but also on behaviors associated. And then up to the moment in which, for example, data on mobility, contacts, and presence at specific places became available thanks to the help of large companies like Google and Facebook. And clearly, as I said, the different questions in different times. And so what I wanted to highlight was how these different questions were posed, and what kind of tension we had on one side with the data, and also what kind of tension we had with the expectations of authorities that were asking this question. And the first, of course, and this is likely is going to be one of the most important memories of a lot of modelers who worked on this, was the very first lockdown. And to put that a little bit in context, France was part of a set of European countries that entered lockdown. France entered lockdown on March 17. A few other European countries were entered lockdown around the same time. And this was just about 10 days after the very first European lockdown that was put in Italy. So we didn't have, of course, any prior into understanding whether lockdown was working or not. And let's say that by the 6th or 7th of April, that we were approaching, so after the third week, we were almost approaching the 1 month after the application of the lockdown. The data of the hospital admissions were clearly showing that lockdown was able to stop the rise, but at the same time, it was yet unclear whether, for example, we were going to stay on a dynamics pretty constant over time, or instead we were going to expect a strong decrease. And the big questions was on this expected impact was, of course, was induced by understanding how contacts were structured. So what was the reduction of contacts associated to the lockdown, and not having any precedent, and not being able, not even to use, for example, the Italian experience yet. But at the same time, the tension was to provide, let's say, within the first month to authorities information on how the lockdown was expected to impact the epidemic. So what we used was cell phone data, and this was thanks to a collaboration that we had prior to COVID with Orange, which is one of the largest telephone mobile operator in France. And we quickly had to, let's say, to work and rearrange this collaboration and ask for authorization in order to access this data for that purpose in real time. So almost real time in the sense that it was just a delay of 3 days. And this was this reduction of the number of trips, given that almost everything was closed, was the information that we used in order to anticipate what was the expected impact of lockdown on the admissions into the hospital before being able to feed it on the data. Of course, we looked at this with different hypotheses because a lot was unknown. And so one hypothesis taking into account, for example, whether people outside home were continuing to establish physical contacts or not, given that recommendations on interacting, of avoiding, for example, contacts in terms of shaking hands, in terms of kisses, which is clearly very popular in France, had been issued, but we didn't know how the population was responding at that moment. And only the data that were later provided by Santé Publique France indeed confirmed that almost the entirety of the population outside of home were avoiding these physical contacts. Now, if we move forward along this timeline and we go to let's say early July this year, of course, conditions are completely different. Somehow we know much more about the epidemic. We know much better about a lot of different mechanisms that are responsible for the diffusion dynamics. But at the same time, of course, this is even more difficult in the sense that there is vaccination, there are variants circulating, there is heterogeneity in space, and there is also, and contacts and behaviors in general continue to be not well captured. We didn't have, for example, regular surveys in order to estimate contacts over time. So in a moment in which all the indicators were still going down, but Delta variant was threatening an upcoming wave, that was the moment in which we wanted to anticipate what was the risk of having another wave, and also how in time, but also in space, so how it was gonna impact the different regions of France. And so what we did in early July was to collect information from different sources, from modeling, through inference, and specifically we assumed that contacts and displacement during the summer 2021 were going to be similar to the contacts and displacements which have been observed during the summer before. So using Facebook data and accounting for different types of risk, which are not only local in terms of what is the fraction of population immunity, either naturally acquired or through vaccination, what is the local frequency of Delta, but also what are the displacements, so how the people are going to move and travel from an area to another in a region of France because of summer tourism, and also how this coupling between different regions will put certain departments at higher risk because, for example, they have a lot of exchange through mobility with populations that have a high frequency of Delta, or with populations which have a low coverage of vaccination. And all of that was used together with some projections over time that our team and Simon's team also produced, were communicated in early July to authorities, and this was likely then alerted on the upcoming risk, and the decision that was taken afterwards by the authorities was to implement a health pass throughout the country in order to access all public places that belong, for example, to like cafe, restaurants, cinemas, etc. And that changed quite a lot the story of the fourth wave in France and during the summer. And then what happened indeed is that the highest risk departments that we predicted to be on the southwest of France were also the ones that 1 month after had the largest explosion and resurgence of cases. Now, it's true that modeling has been used heavily for anticipation and for predictions, and also probably to the general public is what has been retained as almost the sole objective of modeling. But clearly modeling has many, many more advantages, and their efficiency and ability to provide much more information that is not exclusive positively what is going to happen in the upcoming weeks or month. And so one of the other things that we did, and that was somehow a key also into updating protocols for surveillance, was in collaboration with the surveillance team of Santé Publique France at the exit of the first wave. So once the first lockdown was lifted. And that time we were looking at new data, which were the new surveillance data, in which the objective was to systematically and sort of exhaustively try to monitor the epidemic in the country and testing all possible symptomatic individuals, and then from there apply the test and trace protocol in order to find more cases. So on one side, clearly we were dealing with new data, but somehow the question into understanding how well we were doing surveillance, or what was the level of underdetection, is of course an old question in terms of modeling and in terms of analysis that can be done in a time of a pandemic. But at the same time, we knew that all of this was coming together with a lot of changes in, for example, behavior. We knew that healthcare seeking behavior had been changing dramatically before and after the first wave. And for example, we measured through a project that we have in collaboration with Santé Publique France that is based on crowdsourced surveillance. We measured that about only 30 to 40% of people with COVID-like symptoms were going to the doctor. And going to the doctor at that time was critical in order to obtain a prescription to get tested. Otherwise, individuals, even with symptoms, couldn't get tested. And again, looking at the responses of the individuals that were surveyed through this surveillance, we realized that very few were able to obtain prescription, and even lower fraction were going to get tested. So next to that, there was also a change clearly in the dynamics of the epidemic that was also induced by the changes of behaviors. Getting out of the first lockdown in May, people starting, of course, relaxing their behavior and going back to a situation that was closer to normal than what they experienced clearly during the lockdown. And at that point, Google data were available, and so we could use them in order to parameterize age stratified models. And it was probably one of the first approach that used this data at that time with this purpose. At the same time, this had to be complemented by additional data because behaviors were also changing across age, and in terms of respecting recommendations for example, individual preventive measures like avoiding physical contacts. And once again, these were data from Santé Publique France, which helped into tracking how these behaviors were changing over time, and they were changing also across age classes. And what we found out in that work was that the getting out of the first lockdown with a new system for surveillance that was exactly put in place, prepared during the first lockdown and put in place in order to be able to detect as much as possible in the population, we were actually detecting very little. So we, on average, over the month of May, June, on average, we were able to detect 1 out of 10 symptomatic cases. And despite a very low and decreasing incidence, what we saw over time, that is the detection rate was increasing. And this was clearly also a measure of a capacity that was increasing over time, a system that was getting prepared, a number of tests that were increasing, but this was clearly not enough. We looked at how this detection rate was changing across region and across the incidence, and we found that this was dropping very rapidly as soon as the incidence was larger than, for example, 20 cases per 100,000 or 40 cases per 100,000. So very low level of incidences, but still detection rate was already dropped to a minimum, so 1 out of 10 cases. And the possibility to interface different data sets allowed us at that point also to understand that there were additional mechanisms at play, which were not only the capacity, but also how people were behaving. So comparing the estimates that we were able to provide from the crowdsourced surveillance with the model projections, we understood that the largest majority of suspect cases, so of cases with the COVID-like symptoms, were supposed to be tested in order to get to the levels of incidence that we estimated. And so this provided somehow indicated that there were problems likely of access to the test, not only because of the capacity and because of lines, but also because people had to go to the doctor to get a prescription and then go and get tested. And then probably that there was a problem also of awareness in the general population that it was not yet clear that at any possible symptoms people should get tested in a sort of automatic way. And at that point, what happened during that summer, indeed, was that prescription was removed. And so from that summer on, everybody with symptoms or without symptoms was able to get tested in France. And that over time, as soon as capacity increased, this was really helpful into trying to have a better understanding of the dynamics and also better control. And then finally, the last one, this last element that I wanted to talk about was this, aspect of really directly impacting policy into how to manage diffusion in schools and how to safely reopen in schools. France has been one of the countries in Europe with the smallest number of days lost per student because of closure of schools against the pandemic. But nonetheless, now that we have a large part of the population above 12 years of age is vaccinated, our focus remained on the primary school as a possible setting where circulation may still happen, where individuals are not protected by vaccination, and so they could suffer being out of schools and then all possible problems that could happen after, like long COVID, etc. So what we did was to use data from sensors and contacts that allows us to understand how students get in touch within the school, and then use a model that is that takes into account different types of protocols against COVID. It could be, for example, doing nothing beyond isolating cases with symptoms, or reactively quarantining, closing a class, or instead doing a regular screening with different levels of adherence over time. And what we found, that these are results that we've been let's say, communicating to authorities and to the scientific committee since a long time now, but the latest results have been updated to the Delta variant, is that regular screening is what really allows to reduce cases, but also really minimize the number of days lost because of closure of schools or because of isolation of individuals who have not been infected, for example, through a reactive quarantine of the class. And this information at the moment is being used to inform some experimental protocols from the Ministry of Education. And if I have to wrap up, in terms of challenges and probably also leading up to our discussion, I think that as a scientist, besides, of course, the responsibility of the message and the results that we were providing, the biggest problem was really working under this extreme time pressure. So up to what rigor for some results that were used to produce in a matter of months, we were forced to do that in a matter of days. And I find this citation very important because, as Jon was saying before, what we really cared and were very careful about was to always provide very carefully the methodological limitations that were used to produce those results. And not only because of the time pressure, but also because of the limited knowledge that we had. And at some point in time, this was probably the communication that was really hard to make. So the second point is clearly communication challenges in making this understandable to individuals who not necessarily have the expertise or are used to interpret results in light of these limitations. Then I also put a point on transparency, reproducibility, and code sharing, because those are all, given that most of these results were used also to inform public decision making. The public clearly wanted, somehow legitimately wanted access to all of this, but this put an additional burden on scientists on that respect, because all of that, of course, takes time. And then data, of course, some of the interactions worked extremely well, but we had also for a very long time gaps in data into understanding, for example, mobility up to a certain point, to understanding also contacts, into understanding what was happening within the school. And it's not only about building these projects for data collection, which the UK has been pioneering in this respect, but it's also about regulations and speeding up data sharing agreements that need to be done in a time of crisis. So all of this is probably something that we need to think about in a post-COVID setting. And then the advantage was what Simon concluded with, was the one to building a network of this modeling community from which we will definitely benefit in the upcoming months and years. So thank you very much for your listening. Thank you.